Yeah, doctor, we may start now.
Hello, good afternoon, doctors, and welcome to this experience sharing program on managing PPH from Heathrow. Heathrow Healthcare, as you all know, has 25 years of excellence with 36 state-of-art manufacturing facilities, with 100 plus products in our portfolio, presence in 126 plus countries, 21,000 employees globally, and largest closely held pharmaceutical company in India. We are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Heathrow Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Pioneering quality and innovation, and Heathrow Healthcare has distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Heathrow Healthcare, the pioneer in antiviral, offered favipiravir, oseltamivir, and remdesivir to the patients. And in August 20, Heathrow Healthcare received Award of Pharma Excellence for COVID drugs. So today's program, experience sharing program, we have got Dr. Abhijit Annadate as honorable speaker. Sir is consultant obstetrician and gynecologist. Just to speak a little bit about Sir. Sir is obstetrician and gynecologist by profession, practicing since 17 years, medical entrepreneur and educationalist with passion and healthcare at soul. He runs 300-bedded hospital, Anand Multi-Specialty Hospital at Vaijapur in the Aurangabad district of Maharashtra, and is the chief medical director of many of the following institutes: Anand Arvind Medical College, Anand College of Nursing, Anand College of Physiotherapy, Anand International School, Anand Institute of Paramedical Science, and Postgraduate Teaching Institute, Vaijapur, Academy of Medical Education. Sir is Managing Trustee, Anand Hospital, Charitable Hospital, Vaijapur, Director, Anand Multi-Specialty Hospital, Honorary Consultant, Sub-District Hospital, Vaijapur, Honorary Medical Officer, LIC of India, Vaijapur, Vice President, National Social Conference, Pune. With this brief introduction, I hand over the session to Dr. Abhijit. Welcome, sir, and over to you.
Very good afternoon, sir.
I'll share the slides, sir. I'll run the slides.
Fine, sir. So we will be having an overview of a postpartum hemorrhage. Postpartum hemorrhage is actually a nightmare in the life of any obstetrician. Postpartum hemorrhage, as a definition, is a loss of at least 500 ml blood following a vaginal delivery or 1000 ml blood following a cesarean section. Postpartum hemorrhage is common and can occur in every woman who is even not at a risk. Any normal patient coming to you, a primary gravida, blood pressure normal, hemoglobin good, she can turn suddenly in a postpartum hemorrhage. Postpartum hemorrhage is a leading cause of maternal mortality in low economic countries and the primary cause of nearly 1/4 of all maternal deaths globally. Next slide. It's really unfortunate, but yet it is very common. The leading cause of maternal mortality, accounting for about 35% of the maternal deaths. Maternal mortality rate is in developing countries was 240 per 1 lakh live births compared to 16 in developed countries. There is a vast difference between developed countries and the developing or underdeveloped countries. And we all, as in India, we need to strive very hard to come with these developed countries. And I think Heathrow Healthcare is doing the level best in this. So 14 million women suffer from postpartum hemorrhage. The incidence of postpartum hemorrhage or PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean deliveries. 38% of maternal deaths are due to postpartum hemorrhage. It is a big number, 38%. 25.7% of global deaths take place in India, and 2/3 of these attribute to PPH or postpartum hemorrhage. India has unexpectedly high maternal death rates of 540 per 1 lakh live births. It is more than the developing countries. So the etiology, why there is postpartum hemorrhage? So that it can be due to the uterine tonicity, which is more common, inability of the uterus to contract, which may lead to continuous bleeding from the uterus. Thrombin, if she has any coagulopathies, there is a failure in clotting factors. Trauma, uterine trauma, injury to the birth canal, rupture and uterine inversion or vaginal or uterine lacerations. and tissue. If something remains inside after the delivery, if something remains inside the uterus, that is retention of placenta and clots and abnormal placenta. What are the clinical features in postpartum hemorrhage? Abdominal tenderness, circulatory collapse, increasing abdominal girth, loss of uterine contractions, maternal tachycardia, and vaginal bleeding. Now, many times all these things can come, everything can come suddenly and together. So you need at least 2 to 3 good staff with you when we are dealing with postpartum hemorrhage. And the degree of shock in the clinical findings of postpartum hemorrhage is dependent upon the blood loss. If the blood loss is somewhere around 500, it is compensatory shock. If the blood loss is somewhere around 1000 to 1500, it is mild. If it is more than 1500, it is moderate. And if it is more than 2000 or 3 liters, it is a severe degree of shock. The changes in blood pressure, there will be hardly any changes in the blood pressure. But for that, we need to know the initial blood pressure of the patient. The patient should be registered, or if not registered, we should study the notings of the blood pressure in the first, second, and third trimester to see the blood pressure changes. That is very important. There is a slight fall in a mild degree of shock, somewhere around 80 to 100 millimeter of Hg of the systolic pressure. There is marked fall in moderate shock, and there is severe fall in the blood pressure, which comes to as low as 50 to 70 millimeter of mercury in severe shock. The symptoms, there will be hardly, and the symptoms are going to change very fast, very rapidly in postpartum hemorrhage, because there is a large amount of blood loss. Will maybe having palpitations, dizziness, and tachycardia in the compensatory shock. Then weakness, sweating, tachycardia in mild shock, restlessness, pallor, and oliguria in moderate shock, and collapse, air hunger, hypoxia, and uria in severe shock. Next slide. Now, how we do evaluate? There should be a rapid assessment of the patient's status. That's why I told you need to have at least 2 to 3 good assistants, good staff, good OT assistants, good sisters with you. The presence of tachycardia and hypertension, and I think that is hypotension, sir. Presence of tachycardia and hypotension, and assessment of vital signs and blood loss. What can be seen at the time of hemorrhage? Assessment of the entire genital tract. We need to see if there is any trauma, any lacerations, hematomas, and or any signs of uterine rupture. The manual examination of for the retained placental tissue is very important. Assessment with bedside ultrasound to check the uterus, whether it is contracted, or for a ruptured uterus, that can be very helpful. And evaluation of the uterus to check and uterine inversion. Uterine inversion you can see pervaginally very easily in a normal delivery. And what laboratory tests, emergency urgent tests should be done are complete blood count to check the hemoglobin, hematocrit, and platelets, coagulation studies, and assessment of fibrinogen. Next slide. Now, what should be our approach towards postpartum hemorrhage? Attempt should be made to identify the cause in women who are bleeding in parallel with resuscitation. Again, same thing. One person is looking after the uterus, one person is doing intracath, one person has to do a catheterization, large bore intracath should be introduced. All these things should be done parallelly at the same time. You can't do this one after one. You can't do the step-by-step mechanism, because there is torrential blood loss. So poor uterine tone, clinical findings can be the uterus is not contracted. We feel it is relaxed, bogey, and soft. We may feel uterus may be felt above the umbilicus if the uterine cavity is filled with blood and clots. Then again, what investigations is to be done? Then again, same full blood count, coagulation profile, urea and electrolytes, and an ultrasound, abdominal ultrasound if possible. Bedside should be done very fast, very urgently. if the patient is not responding to the fluids and blood replacements. What drugs are to be given? Again, oxytocics, prostaglandins, ergot alkaloids, and last thing, uterine balloon tamponade can be used if there is huge loss or the uterus is not contracting or there is a tonicity. If there is a trauma, tears, and the blood for bleeding from the areas of trauma with genital tract or uterine rupture, extension of uterine angles, even in cesarean section, tear can be done in, can be there in cesarean also and normal deliveries also, and extragenital causes such as subcapsular liver rupture or rupture of ovarian or splenic vessel, which is a bit uncommon. Investigations in a cesarean, you should exturiate the uterus. Everything can be seen very nicely. Ultrasound if possible. Rapid identification of the genital tract trauma and pelvic arterial embolization where cath lab facilities are available, maybe can be done. In a retained tissues, clinical findings, retained placenta and membranes, you should be identified by biomanual examinations. Examination should be done under anesthesia, and the manual removal of placenta, retained products of conceptions can be done under regional or general anesthesia. A short GA can be given. In case of coagulopathies, coagulation bleeding, contracted, continuously bleeding, there is contracted uterus, the blood investigations, full blood count, coagulation profile, urine, electrolyte must be done, and immediate replacement of blood and coagulation factors, and the if possible and if needed, platelet should be given. And surgically, only when trauma is there and there is atonic uterus, which is unresponsive to the medical treatment, we can go for surgical management. Next slide. Now, why rationale for the developed? Why carbetocin? Why a derivative of oxytocin has to be formulated or has to be came in the market? Why this drug has come in market? Because this is a new heat stable carbetocin is a new heat stable formulation, because it is available in room temperature and the normal conventional vial presentations. The routine oxytocin what we give are ergot alkaloids should be which has to be kept in refrigerators to avoid degradation. Heat stable formulation of oxytocin is currently not available. Previous formulations of carbetocin should be stored in 2 to 8 degrees centigrade. The poor countries did not have that cold chain transport, and even in India we don't have good cold chain transport facilities in villages and small towns. Carbetocin is stable at room temperature. The has shelf life 24 months at 30 degrees and 75% humidity. It avoids need for cold chain storage and logistics. Is provided in a vial. The use of uterotonic agents, and it should be done. What we use is most of the people use at the third stage of labor, at the time of crowning of the baby's head, at the can be used at the delivery of anterior shoulder, can be used at the end of second stage of labor, and can be used following the delivery of placenta. The prophylactic use for the prevention of postpartum hemorrhage, maximum hospitals prefer active management of third stage of labor. And the therapeutic can be given for the management of postpartum hemorrhage, that is after postpartum hemorrhage gets set in. The molecules are oxytocin, carbetocin, ergometrin. Then symptometrin is a combination of ergometrin and methergin and oxytocin and tablet misoprostol. Next slide. The carbetocin is a next generation drug for postpartum hemorrhage. It is a wonder drug, I would say rather. Carbetocin was created by making several modifications in the oxytocin structure, which prolongs the half-life of the regular oxytocin drug and reduces the enzymatic degradation of the drug. It is a synthetic long-acting analog of oxytocin. It is used in prevention of postpartum hemorrhage due to uterine atonicity, and only vial contains 100 microgram of carbetocin in 1 ml solution, which is used as an injection. Next slide. Now the clinical evidence, efficacy and safety of carbetocin versus, we can directly go to the difference between oxytocin and our heat stable carbetocin. What is oxytocin? Is a synthetic cyclic peptide from the natural occurring posterior pituitary hormone. It is a natural hormone which is present in our body. It binds to oxytocin receptors in the uterine myometrium, stimulating contraction of the uterine smooth muscles by increasing the sodium permeable of uterine myofibrils. Whereas it is carbetocin is a long-acting synthetic analog of oxytocin with agonist properties, which binds to oxytocin receptors and contracts the uterine muscles. The pharmacokinetics, it is almost immediate action within concentration after 30 minutes. It can be given IV and IM both. Carbetocin is also given both IV and IM. IV sustained uterine contractions within 2 minutes, lasting for about 6 minutes and followed by rhythmic contractions for more than 16 minutes or 16 minutes. Intramuscular sustained uterine contraction lasting for 11 minutes and rhythmic contractions for 120 minutes. The half-life of carbetocin is 40 minutes, whereas half-life of oxytocin is only 1 to 6 minutes. The most important part, why carbetocin is preferred, is the storage, because oxytocin requires a cold chain maintained from the factory to the patient, whereas this is a heat stable which can be stored at 30 degrees centigrade. Oxytocin needs to be stored at 2 to 8 degrees centigrade continuously. Now, what WHO says about this drug, carbetocin hemorrhage prevention. There was a large clinical trial performed by the World Health Organization for non-inferiority double-blind randomized trial for the objective of to compare the effectiveness and the safety of investigational heat-stable carbetocin to oxytocin in the prevention of PPH after the vaginal birth or even cesarean birth. 30,000 patients were enrolled across 10 countries, including India. And the proportion of women with blood loss of at least 500 ml of the use of or the use of additional uterotonic agents. The proportion of women with blood loss less than or at least 1 gram or 1000 ml of blood loss. Next slide, sir. Here the difference was the efficacy of carbetocin was in decreasing the blood loss was 14.5%, whereas oxytocin it was 14.4%. The blood loss, where blood loss more than 1000 ml, it was 1.51%, and it was in oxytocin it was only 1.45%. And the safety profile was 4.9% as compared to oxytocin 4.7%. And at least in one serious AE, it was 0.7% as compared to oxytocin, it was 0.6%. The frequencies of the expected AEs did not differ significantly between the two groups. But we need to mind that the oxytocin which used by in these controlled trials was completely maintained in the cold chains. The frequency of blood loss at least half liter of or the use of additional uterotonic agents with carbetocin was proven to be non-inferior versus oxytocin, and the use of additional uterotonic agents, intervention to stop bleeding, and adverse effects did not differ much significantly between the two groups. So the conclusion was carbetocin was not inferior to oxytocin. Rather, I would say, my experience, it is superior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. Now, what the Cochrane review says, the most important Cochrane studies for women who undergoes a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonic compared to the oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin, which is a combination, in the prevention of postpartum hemorrhage for women who have vaginal deliveries and is associated with significantly fewer adverse side effects. So, if we see all the guidelines, WHO, it was 2018, which was saying carbetocin as the second drug. After that, in 2009, Canada is saying IV bolus carbetocin as the first drug for prophylaxis of postpartum hemorrhage. Active management of the third stage of labor. Again, New Zealand also uses the same drug. FIGO, the international organization, also says carbetocin is has recommended as carbetocin for the prophylaxis of postpartum hemorrhage. Germany, Austria, Swiss bodies also prefer the same drug. Same 100 grams low IV. France also says carbetocin on proving the non-inferiority of the oxytocin after the WHO trial. Next. So all over globally, the world has accepted carbetocin. So these are few cases which we have observed in our hospital, which says that the use of carbetocin given immediately after the delivery of the placenta as a prophylaxis to prevent postpartum hemorrhage and as a part of active management of third stage of the labor, and we have achieved excellent results. Good uterine contractions, good control of blood loss, and we hardly need any additional. I think I have given 2 to 3 cases additional uterotonic and reduce the risk of delayed bleeding and postpartum hemorrhage. And no, absolutely no side effects I have till today I have observed with the use of carbetocin. Next case. The next case.
Sir, thank you very much. We'll come to the questions. So you said about your experience about your using carbetocin, you have used extensively. What is the route of administration you have generally preferred, sir?
Intravenous, sir. IV.
IV. Is it bolus or with a drip?
No, sir. IV bolus somewhere around 1 to 2, 1 till 1 minute.
1 to 1, yes. And any patient profile where doctors can anticipate a PPH?
Sir, if the patient is having previous history of postpartum hemorrhage or multiple pregnancies, anemia, in a history of prolonged and rapid both, precipitated labor also or prolonged labor also, there can be definitely we need to anticipate PPH.
Maybe
severe
diabetes
PIH,
also.
yes, diabetes, severe PIH, eclampsia, pre-eclampsia, big baby macrosomia.
Oh yes.
Uterine
twins.
Tony, then instrumental or even in cesarean, there is a bit more chance of postpartum hemorrhage, and again retained placenta or genital trauma.
And of course, uterine atony, any cause of uterine atony is a big risk for PPH.
Is a big risk for
yeah. Where would you prefer carbetocin or oxytocin for prevention of PPH?
Very frankly, now I have stopped using oxytocin.
Obviously,
in cesarean, all high risk, because first thing to be even after delivery also, previously we used to give 20 units pitocin drip and all those things.
Correct.
Now after carbetocin, there is absolutely no need to use any drug, and in very less cases we need to add the uterotonic drugs. And
finally, life is at stake. We can't take risk if something is working.
Yes, definitely. So
once upon a time, we had only oxytocin and methergine.
दुसरं काहीच नव्हतं तेव्हा.
काहीच नव्हतं. And then belief, bas.
Yes.
Can we use carbetocin in case of retained placenta?
100% we can use carbetocin.
Yes. Of course, remove a placenta and then use it. And in RH negative mothers, sir?
No problem. No, absolutely not.
This could be an emergency in the interiors, especially if RH negative, then transfusion could be an issue. Getting RH negative blood could be an issue.
But there is a very bad state of affairs in government setups.
Oh.
Still today, they are, I don't know where I am going as an honorary. I have to take my own carbetocin always. मी माझं घेऊन जातो. कुठे ते ड्रीप आणि ते पिटोसिन.
The basic advantage is that practical advantage. A single bolus injection, you don't require paramedical help, which is important in interiors. आपण बघतो तसं.
खूप एक इंजेक्शन दिलं की फटकन फरक पडतो.
Can a doctor use carbetocin for prevention of PPH if oxytocin is used for labor induction?
Yes, carbetocin can be used. We use it routinely because the induction ka dose of oxytocin is hardly 5 units.
And the short life is, I mean, half-life is very short.
So half-life is
Very, very short. So it will come out. Do you prefer IM routes anytime?
very rarely.
Really? Not a choice.
No. Because we even in case of a normal delivery or in cesarean, we have an IV cannula.
Oh, yes.
There
Why
are
is
hardly,
it
like last more than 3 years, I think we are using
IV?
no
Perfect.
contraindications.
Correct.
So we use.
If a patient is not responding adequately with carbetocin, what would be additional uretonics would use in your order of preference?
Then first line we go for carboprost.
Carboprost.
And at the same time, what we do is if there is like post atonicity and the patient we have given carbetocin, patient is not responding, intramuscular carboprost is given only in intramuscular.
Yes.
Is given, and at the same time, what we do is then we don't wait for the next drug. Then at the same time, we insert 4 tablets of misoprostol.
Over.
And
That's
then
it.
even if the bleeding is not stopped, then we start 20 units of oxytocin. Although after carbetocin, we hardly oxytocin is going to help. But then again, आपल्या मनाचं समाधान.
नाही, बरोबर आहे. Correct.
So the
We try
third,
everything that's with us.
everything जे काय हातात आहे.
Everything.
And methargine also. But methargine will be the last, I think.
Last, yeah. Blood pressure fluctuations.
Yes. काही नसेल.
And sir, how much role anesthetist has got in all this?
Anesthetist, they keep in the hand only. Immediately we take out the cesarean, we take out the baby out.
Correct.
They don't even ask us.
So anesthetist only starts carbetocin.
Anesthetist gives immediately.
So anesthetist comes into action in any time.
The baby is out, the anesthetist gives.
Takes over. And advantage of carbetocin over oxytocin, especially the ADH type related side effects. Huh?
First thing, though, there are no side effects. Second, most important is again, I am telling for so many times, I told in my talk also, because the heat stable, it is a heat stable area.
Yes.
So all the way from the factory of somewhere around South India or Bombay or somewhere, from there it comes to my place. Then it is for some time in that yard of the transport agencies, and then it comes to us. So it is
cold chain.
I think we get some in 5 units we get efficacy of 2 units or 3 units.
And Mumbai, there is a power outage so commonly happening. Even in chemist shop, we do not know. Everywhere we do not know. Generator should be acting, I mean, we have no control.
Bombay is it okay? What to do in places like my place where पावसाला 7 slide जाते.
Correct.
Becomes difficult.
And over misoprostol?
Misoprostol can't. It is a tablet form. It is not. It can't be given, and it takes a time.
Carbon tablet metal, it will take time. And Puna misoprostol, carboprost, the prostaglandin related side effect would be there.
Yes, definitely. Carboprost, we can't give carboprost in asthma.
Oh yeah.
Absolute post.
And methyl ergometry in hypertensive.
Hypertension, asthma.
Cardiac, yeah. You have answered this question. Should be kept as a reserve.
No, it is not a reserve.
It
should be the first.
This also question you have answered. Sir, last question there are people who are little skeptical of using carbetocin. What is your take-home message for those doctors who are little skeptical, little hesitant to use carbetocin vis-a-vis your experience of efficacy, tolerability?
Don't hesitate at all when you are using carbetocin. You just close your eyes, you tell your staff, you tell your mama, you tell your sister, whoever, if there is an interest, if there is a cannula, you immediately go for IV carbetocin. Or if there is a precipitate labor, there is no the intracath is not there, you directly give intramuscular carbetocin. It is absolutely efficient drug, high levels of safety, and tolerable by everyone, each and every female. So you first line drug, just close your eyes and start it. Give it.
Thank you, sir, very much, sir, for sharing your experience. Thank you very much. Because किती पेपर असेल तरी practical experience is practical experience and which matters to us. Thank you very much
पाहण्यासारखं
for.
वापरतो सर आम्ही आता.
Yeah, and
छान
it,
आहे बिलकुल.
it matters too. Now, finally, that practical experience is the only thing which will help doctors. Thank you very much. Thanks,
Thank you.
marketing and sales team of Hitro, and thanks all the doctor who took time and attended this session. Huh? And thanks IT team for super coordination. Thank you sales team. Thank you marketing team. Thanks Pivas for coordination. Thank you sir once again, and wish you a
Thank
very
you,
good
sir.
afternoon and good evening.
Thanks, sir.
Thank you.
Thanks. Thank
Nice
you.
meeting you, sir.
Yes, sir. या सर एकदा भेटूयात.
Oh yes.
Yes. Thank you, sir.
Bye. We can log out now.
So thank you so much. Thanks a lot, sir.
हो गया?
हाँ
Yeah,
सर.
thank
Okay,
Thank
sir.
you
We can
very
log
much,
out,
sir.
sir.
Thank you.
so
Thank you,
much.
sir.
Thank you, sir.
Thank you. Thank you.